Hello and welcome. It's 6 p.m. UK time, so it is time to start our event. And I'm Caroline, your host, as always. And tonight we have another special guest, another doctor and another topic to discuss. With us today, we have Dr. Rosa Trigas. Hi, Dr. Trigas. How are you feeling today? And I hope you can hear me well.
Yes, hi. Thank you very much. And well, I can hear you very well. Thanks for introducing me. As you said, I'm Dr. Trigas. I'm working at Institut Marquès. Institut Marquès, you might know, is one of the top main integrated centers with a well-established international recognized reputation in the fields of obs-and-gynae and reproductive medicine. And every year, hundreds of patients visit Institut Marquès from abroad, hoping to achieve a pregnancy, mainly through IVF with egg or sperm donation. We are headquartered in Barcelona, and we have additional offices in England, Ireland, and Italy. With more than 95 years of history, Institut Marquès, the fourth generation of gynecologists of the Marquès family, continues to deliver stunning results. Nowadays, it has become an international reference for assisted reproduction. We are leaders in excellence-based medical care, and we treat patients from more than 50 countries. We have a broad portfolio of services, and we have the best success rates, reaching 91% per cycle in vitro fertilization with donor egg. We specialize in special hardship cases of patients with fertility issues. That means those who have undergone previous several cycles without success. We have the added value of being a reference in both the study of male infertility and pre-implantation genetic testing. And we have also a sperm bank and a broad donation program of eggs and embryos. So I think that resumes in a nutshell what Institut Marquès is. Today, the topic is about tailor-made protocols. So why it is important to have a tailor-made protocol? Well, first of all, having a proper diagnosis and a proper treatment according to this diagnosis is key to have a successful treatment, which is what we want. We all want to have a successful treatment, successful pregnancy, and a baby, okay? Tailor-made also means to adapt to the circumstances of the patients, especially now in these special circumstances of coronavirus. We've been adapting as well to the requirements of the patients. For example, patients are scared to travel. We can offer them the option of sending the sperm with a system called Freeze Kit, and then they don't have to travel now that traveling is a bit restricted. So we have to adapt to both medical and personal circumstances of the patients, and I think we are great doing that, okay? So we cannot treat all the patients the same. We encounter sometimes patients who have done many treatments before with no success, and when we look into detail on the histories, we find they haven't been diagnosed properly. If you don't have a proper diagnosis, you won't have a proper treatment. Some patients, for example, might have an egg factor. So when the quantity of the eggs is affected, it's important to adapt the medication to the patient, because we want to get as many eggs as possible, but also we need to avoid hyperstimulation. So we need to adapt the medication to the age of the patient, the body mass index, previous treatment, etc. Sometimes it's not a problem with the quantity of the eggs, it's the quality of the eggs. So that generally is due to age. In these cases, apart from the medication, we need to look into the genetic information of the embryos, because the embryos might be affected by the age of the woman. So in this case, we need to offer PGT, the pregenetic testing of the embryos, to make sure we are transferring one embryo that is genetically normal, okay? These embryos, due to age, might have kind of a hard shell around, and that makes it difficult for the embryos to get out of the shell and implant, so they might benefit from something called hatching. That's something that we need to take into account, looking at the history of the patient, her age, her previous cycles, etc. So hatching might benefit this couple or this patient. Sometimes also we need to consider doing microsurgical fragment removal. That means that the quality of the embryos might not be good. They might have little fragments in between the cells, so we can remove them and the embryo becomes better quality to implant, and that increases the success rate. So all these things need to take into account when you see a couple. Sometimes, unfortunately, we have to tell the patient, you cannot do treatment with your own eggs, but we can offer them the egg donation program. We have a broad egg donation program. It's very successful. Lots of patients from abroad come to Institut Marquès to do it, and I think we are doing that very well, and I'm proud to say that every day I'm helping my patients by choosing the best donors for them. Even in the case of egg donation, we have to individualize. I mean, I need to think what the patient wants from the donor. Depending on the country, she might prefer these embryos created with the egg donor to be sent abroad, etc. So we need to adapt also to the, as I said before, to the personal circumstances of the patient. Other patients might have infertility due to male factor. It's not only an egg problem always, okay? So it's a male factor as well. And again, a proper diagnosis is required. Sometimes a normal sperm test is not enough, and we need to look, for example, into the genetic quality of the sperm, that's called FISH, or we can look into fragmentation. We find sometimes that patients come here, they don't know what, they haven't been successful, they haven't been studied properly, and these things need to take into account. So if you do a proper diagnosis of the male factor, you might decide what is the best treatment. Sometimes could be as easy as changing, making lifestyle changes, or sometimes we need to analyze the embryos by doing PGT, or we need to do a better selection of the sperm by doing something called IMSI. Selection of the embryos is also key. You probably have heard about the embryoscope. The embryoscope is a camera we put on top of the embryos, and instead of having to open the incubator every day to give them a score, they are all the time watched. So we don't open the lid, they grow better because we are not changing the temperature. And the other advantage is that it's creating like a video by taking several pictures. That means that if you, for example, have two embryos that look similar, but you're able to see the video of how they were developing, you might choose the best embryo to transfer. That's also something to take into account when you have patients who haven't had successful treatments before. Other patients might have a uterine problem. I mean, if you have, for example, chronic inflammation of the lining or an infection, you might have beautiful embryos and they might not implant. So we need to treat them before we do the embryo transfer. That's something important. It's not only about the eggs and the sperm, it's also about where you put these embryos, about the uterus. It's important. Then sometimes we have patients with recurrent implantation failure or recurrent miscarriage. They might need extra tests and different treatments, like something to regulate the immunological environment of the patient. But sometimes you have other type of patients where the issue is that they don't have a male in their situation, either single ladies or same-sex couples. In this case, we can offer them the premium sperm bank. Again, we have to individualize, okay? So we have to choose a donor that is suitable for the patient. But for example, in same-sex couples, we can also give them the option of doing something called ROPA, which is very interesting. That means that, for example, one of the women of the couple is doing the stimulation of the eggs, so she's kind of the egg provider, let's say. We fertilize them with the sperm of the donor, and these embryos are transferred into the other lady of this couple. So they both feel that they are part of the process. I think that's very beautiful and interesting. Other patients, because of age and personal circumstances, what they want to do is just freeze the eggs. Egg vitrification is a very good option nowadays, because with the current advances in the labs, we are able to keep the eggs in very good conditions. And other patients might benefit from embryo adoption programs. So as you can see, there is a broad range of options, and the option of one-size-fits-all approach is not a good thing, and we have to individualize and do our best to help our patients both medically and personally. I hope I didn't extend myself too much. And if you have any questions, please let me know.
Excellent. Thank you so much, Dr. Trigas, for your introduction. And now we will go for those most common questions. And after that, this will be time for your questions. So as always, please remember to type the questions in the chat section, and Dr. Trigas will simply answer them one by one for you. So don't miss out on this change, and you just type those questions in. All right, sorry. Now, let's go to the very first question here. Is it necessary to undergo hormonal treatment for the ovarian stimulation during IVF? Do all women react the same?
Okay, thanks. Well, I start with the second question. Do all women react the same? No, of course, no. The response to the hormones of the treatment we give, it will depend on many factors. The first one probably will be your age and your egg reserve. So what we do with this medication, we stimulate the eggs you already have, trying to get as many as possible. If you have a low ovarian reserve, you're not going to respond the same as a lady who has a good ovarian reserve. The response will be different. Of course, we will try to adapt the medication to do our best, but you cannot expect the same response. Also, it depends on, for example, your weight, your body mass index might affect how you respond to the medication. Some women might have certain resistance to particular medications, so we need to try different medications. They don't respond the same. They do not respond the same, all the patients. So taking that into account, is it necessary to undergo hormonal treatment for the ovarian stimulation during an IVF? Well, the idea of the ovarian stimulation is to optimize the treatment. So if I give you a hormonal treatment, the idea is that I'm going to get, let's say, 6, 7, 8 eggs, okay? If I get then 8 eggs, and I guess, for example, you get 5 embryos out of these 8 eggs, your chances of getting pregnant are going to be higher, because it's more likely that I will get, some good embryos out of this pool of 5 embryos. So what I'm trying to say is that we kind of try to get as many as possible to optimize your chances with one treatment. Having said that, there are women that unfortunately have a very low ovarian reserve. No matter what you give them, they are going to respond only with one egg. In these cases, if you're talking, for example, about a lady who is young, that you assume the quality of the egg is going to be good, but she only produces one egg, in these cases, I think is acceptable to do what's called natural IVF, which means you don't give her any hormonal treatment. If she's going to get only one egg with ovarian stimulation, you might as well do it natural, because in theory the quality might be better of these eggs without any hormones. So in this case, I think it's a good idea to do natural, but in any other cases where you have an acceptable ovarian reserve, I think by doing hormonal treatment, you're optimizing your chances. And, I think it's important.
Of course. Well, thank you so much for answering the very first question. And now let's go to the next one that we have here. So is it possible to undergo donor egg IVF treatment without freezing the eggs?
Well, as a matter of fact, in Institut Marquès, we generally, what we like to do is work with fresh eggs. That we have a broad pool of donors. We have our own, bank of donors that allow us to call these donors and start a fresh cycle. That means that we will synchronize the patient with the donor, so they get the period more or less at the same time, and they are synchronized all the time. So this way, the patient gets a fresh transfer, and it came from a fresh pool of eggs. Having said that, if by your special circumstances, if because you are traveling abroad, if because you change your mind, etc., we can use frozen eggs if needed. But generally, we like to work with fresh. They give us a better result. We understand that's the best treatment, and this is what we're offering to our patients. So it wouldn't make sense to offer them frozen when we have the option of doing fresh. I know not everybody has the option of doing fresh, but if you have your own bank, that's something you can do. I can call the patient, the donor myself. I know the patient, I know the donors, so that allows me to do a good matching. And then I call the donor, I start the process, and they go synchronized. And I think that's beautiful.
Perfect. Thank you so much again for answering this question. And next one is here. In a donor egg IVF treatment, how will the right donor be chosen? Which criteria are taken into account?
Okay. So, well, first, I will ask two questions first. One, the donor, is she a good donor? And second question, is she a good donor for you? Then the first one is what we have to do when we have, when we decide if we can accept the donor or not. So donors, they have to be obviously healthy, and if they have any medical history of any illness, they cannot be donors. We have to be very strict with the donors we accept. They have to be less than 35 years old. And we are doing a very thorough screening. We start with a psychological test. It's important to see that they don't score high for tendency to, for example, depression, anxiety. A psychological test, I think, is important, and some patients value that very much because they don't know the donor, so at least they want to have this reassurance. We do obviously an infection screening, make sure they don't have hepatitis B, hepatitis C, HIV, the most important infections. And we do a karyotype. We check that their chromosomes are normal, and we check that they don't have any mutations for cystic fibrosis, because this is one of the more severe and frequent mutations that you can have and detect nowadays. So if she's a good donor, good age, good medical history, good ovarian reserve, and she passed all the tests, then the second question is this donor good for you? Then what I do, how do I choose the donors? First of all, I have to speak to the patient. Of course, I take into account the physical details and blood group. That's the most important thing. But I also ask them, what is important for you? Because apart from, you might say, I'm blonde with blue eyes. Yeah, that's fine. But maybe for you it's important that in your family everybody has, wavy hair. Well, I can do my best to try to fit that. What is important for you? Maybe I don't see it, but if you tell me, I can try to fit that into the search of the donor. So it's not that we have a small number of donors, we have a broad numbers and we can choose. So as I said, first thing is check that the blood group and physical characteristics are the same, but I take into account also what the patient is telling me, what is important for her. So that's how we do the donor search.
All right, excellent. Thank you so much once again for explaining all the details on that question. Next one is quite ready as well. When is it necessary to resort to sperm donation? How can male infertility be diagnosed?
Well, male infertility. Well, we know that the quality of the sperm is decreasing nowadays, probably due to contamination. We are currently doing a study about that in Ireland. And there are different levels of diagnosis of sperm abnormality. The basic thing will be to do a medical history, fertility history, and then do a sperm test to evaluate the count, the number of spermatozoids, how they move, how they look like. That's called morphology. So this is the first test you do, and you evaluate. We have to take into account the whole history. I mean, you might have a perfect sperm, but if you have a long history of infertility, you might think that this test is not enough. Maybe we need to look into more detail into this sperm and evaluate if genetically this sperm is okay. So that's a test called FISH. Not everybody needs that. As I said, you need to take into account the the history of the couple. Sometimes, for example, if the male patient has a history of heavy smoking or any toxic factors, we might evaluate doing a fragmentation to see what's the quality of this sperm. So a sperm test is not enough sometimes. Sometimes it is, but sometimes when it doesn't fit into the picture, the infertility, you think, yeah, it looks normal, the sperm, but something must be going on because the age of the woman is right, the tubes are open, there is nothing else going wrong. Let's see if there is something else. So it will be a different level of investigation, checking the fish and the fragmentation of the sperm. Then when do we need to use a sperm donation? Well, there are probably 4 different groups. One of them will be obviously single ladies. They will use the sperm donation, and for that we have the premium sperm bank here. Then there is the same-sex couples, again, situations similar to the single ladies. Then there are patients where the man has no sperm, that's something called azoospermia. And when I say no sperm, I mean that they haven't even tried, for example, to retrieve it surgically. And when this is definitely a situation of no sperm, then they need a donor sperm. And then the 4th scenario is a bit more complicated, is when there is a sperm, but the quality is not good. You do many cycles, they don't work well, the embryo quality is not good, you think it might be a sperm factor. Eventually you decide, well, maybe we need to do a sperm donation. It might not be easy, this decision, and sometimes we only can do what's called half and half. It means that you might use half of the sperm of the patient and half of the sperm of the donor, trying to respect the fact that the couples, they might not be completely ready for the donation, but at the same time, they want to have a baby, you need to have them. So we can compromise this way. So I would say this is the 4 scenarios where you need to have a sperm donation.
Perfect. Thank you so much for answering this question. Now it will be our last question when it comes to those most common ones, and then we will go for your questions, and there are quite a few questions ready. So let's go to this one. Is it legal to use the sperm of a friend for my treatment?
Okay. Is it legal? It depends in which country you're asking me that, okay? So let me tell you the current legislation. To use the sperm of your friend means that you're using a non-donor, a non-anonymous donor. So non-donation or non-anonymous donation, you can do it, for example, in Ireland. Like, for example, we have a clinic in Ireland, and this is where we are doing treatments with non-donors, okay? So a non-donor means that you either provide the donor yourself or you buy the sperm from a bank where they have non-anonymous donors. So in particular, in certain countries, you can do that. Like, for example, we do it in Ireland. Okay? If you use a friend, you need to bear in mind that they will have to do some tests on this particular person. They will have to do some infection screening and genetic testing. Even if he's your friend and you know him, I mean, that doesn't mean that you don't have to check the quality of the sperm and this male donor, okay? So in these countries, like Ireland, also UK, you can do, and you all only can do, as a matter of fact, non-anonymous donation. If, for example, we are talking about doing treatment here in Spain is only allowed the anonymous donation. That means that you cannot bring your friend as a donor, but what you can do is use our bank. We have our own sperm bank where we will choose the donor that's more suitable for you and with all the guarantees. You will be able to know physical characteristics, age, blood group. We won't be able to provide the name because is by law it has to be anonymous donation.
And perfect. Thank you so much
You're
for
welcome.
answering those most common questions. And of course, now it is time for our patients' questions. And as I mentioned, there are plenty of those here already. So are you ready for them, Dr. Trigas?
Yes, I will do my best.
Excellent. Thank you for confirming that. And well, let's start with the very first question from our patient. It's right here. I am 43 in early ovarian failure with fibroids, one inside the uterus. What do you suggest are my chances or options?
Hi, say, well, okay, tough situation. There is two issues here. One of them is the early ovarian failure, as you have mentioned. The other will be the fibroids. Well, I think that if you are 43 and by saying that you have early ovarian failure, you mean that you have a low ovarian reserve, I think that trying do an IVF treatment, for example, with your own eggs will be a bit tough because not only the quantity is affected because you're saying that you have an ovarian failure, but the quality of these eggs is going to be affected. You have to think that at this age, maybe if you are able to get 5 embryos, maybe only one of them will be genetically normal. That means if you are able to get 5 embryos that get to day 5 and we can analyze them. So I think it's a bit tough, and I think you should consider an egg donation program. About the fibroids, well, it depends on the size of the fibroids. Probably the ideal thing will be to do a hysteroscopy. I don't know the details exactly of the size of your fibroids, but the main thing is checking how much is affecting the cavity. If it's affecting the cavity, but we can remove it surgically, then it's okay. We can leave a cavity that is okay for the transfer. And that probably can be sorted out. But the issue of 43 with low number of eggs, I think is a tough one, and I think your best option will be egg donation.
Thank you for your question and answering this one, and for your advice, of course, as well. Next question is quite ready as well right here. So what medication, gonadotropins, do you usually use for women with low ovarian reserve?
With women for low ovarian reserve, we try to use high dose of medication that has both what's called FSH and LH. Is a combined hormonal action, trying to compensate for the low LH action of the women that they have low ovarian reserve. But sometimes, apart from that, we can add other treatments. Like we can consider to do a treatment before with estrogens or with the pill. Some cases we can use kind of testosterone for a while, trying to increase the chances of this woman to respond later to the medication. So it's not just the medication you give during the cycle, it's also what you give before the cycle sometimes.
And thank you once again for that question. And the next one is actually from the very same patient here. Do you do any pre-treatment before these cycles, and what kind?
Well, I kind of almost answered that.
Yes, that's true. But if you could add anything.
So as I said, it depends. I mean, it's not always necessary. If you have a patient with a good ovarian reserve, then you don't need to. But in patients that you might suspect that they might have a low response, or they might have something called non-synchronized response, that means that if they have, for example, let's say 4 follicles, one of them is going to shoot out and the others are not going to respond. You want all of them to grow at the same time. So sometimes we can do a treatment before with, as I said, estrogens, contraceptive pill, testosterone. So yeah, we have to consider case by case, but yes, we do treatments, pre-treatments before.
Excellent, thank you. And actually there is a follow-up, so let me go straight to that one. So do you use HGH, growth hormone, as pre-treatment?
The growth hormone, I know there are some studies that suggest that might increase the response to the treatment, but currently, as far as I know, is not used. We need probably more studies to determine that is worth to use it. So there are many things, many treatments out there, propose that there are things that they might increase the success rate of treatments, but they are not evidence-based. So this is one of these treatments that probably might help, but we need probably more studies until we can do that clinically to all the patients.
Understood perfectly. Thank you so much for clarifying this then. So what tests and cures do you recommend to check for chronic endometritis?
We start with the test we will do. So when you suspect somebody might have chronic endometritis, I think what we need to do is have a look to the lining where the endometritis occurs. So how do you do that? You do that with a hysteroscopy. That means putting a camera through the neck of the womb inside the cavity and have a look to how this tissue looks like. That's the first thing, but that's not a diagnosis. Then what you have to do is take a sample of this tissue and analyze it. So that's called biopsy, and you have to do also a culture to see if there is an infection. So in summary, it's a hysteroscopy with an endometrial biopsy and culture. If there is, if we can see, for example, plasmatic cells on this lining, on this endometrium, we might need to do treatment with anti-inflammatories. If there is also an infection added to this inflammation, we will need to do antibiotics. So depending on what we find, could be a combination of anti-inflammatory treatment and antibiotics.
All right, perfect. Thank you so much again for that. Okay, actually, just give me a second. I'm just checking. There's a... Okay, sorry, there's a follow-up. How is this test of endometrial biopsy called?
Well, I think the endometrial biopsy, the name is as it sounds, is endometrial biopsy, doesn't have any other name. But maybe what you are asking is how we do that. We do that through a hysteroscopy. The hysteroscopy is the camera we put inside. And the endometrial biopsy is called endometrial biopsy. Then, of course, on the market, there are many brands that they check different types of infections as. There is the Emma, the Alice, but the procedure itself is an endometrial biopsy and culture. And then different labs might have a different range of bacteria and microorganisms they are checking, like Emma and Alice. They are different, but the idea is the same.
All right, excellent. Thank you so much for that clarification as well. Someone is typing, so I just want to make sure that we... Yes, it seems like it. If not, we will go back to this follow-up as well. Okay, next, yeah, it's just... thank you for answering the question, as you can see right here.
You're welcome.
And of course, let's have a look at the next question we have. Is hormonal stimulation necessary for insemination with donor sperm?
It is not necessary, is recommended. Okay, so if you want to do a natural cycle with donor sperm, of course you can do it. What we have to do is do kind of ultrasounds very often to make sure we don't miss ovulation. Okay, but what we see is that when you do stimulation of the ovaries, trying to get 1 or 2x, the success rate of insemination increases. So having said that, if you already have regular cycles, you're a young woman with quality eggs, and you want to do a natural, I don't see a reason why not to do it. But the recommendation will be to do it stimulated, because this way you ensure, you're going to have a proper ovulation. You know when it's going to happen. We can time when is the insemination, going to happen, because we give you an injection to release the egg 36 hours later. So it makes it more successful. And I have to say, you might need only 10, 11 days of medication of a low dose hormone. So it's not that bad, but we can do a natural insemination if the patient, that's what she wants. We were talking about that before. We need to adapt also what, the patient circumstances, preference, etc.
All right, excellent. Thank you so much again for answering that question. And now let's have a look at a bit longer question as well. And of course, there is a thank you from the patient right here for you.
You're welcome, Maureen.
Perfect. And the question is here. I am 36 and started the fertility process with the hospital at Klein, Dublin, but the process was paused as a result of the virus. I was diagnosed with fibroid at some time. Last month, I noticed that I was pregnant and bleeding heavily, and I miscarried. Is this as a result of the fibroid? What are my options?
Okay, Onyeci, it's not easy to answer this question because I don't know, for example, the size of the fibroid. Fibroids that are a big size and they are impinging into the cavity, so they are affecting the cavity. They might affect the, let's say, the blood supply of this area, and sometimes that makes it difficult for the embryos to implant and grow properly. Having said that, one every 10 pregnancies ends up in a miscarriage. It's just at 36, it's probably just bad luck that the embryo didn't form well. So I won't be able to tell you if it was a result of a fibroid. I think the first thing we need to know is this fibroid into the cavity and how much is affecting the cavity, because this is affecting a big portion of the cavity. Probably I will recommend you to remove that. If it's a small fibroid that is not impinging and is just sitting, next to the lining but not in the cavity, then I wouldn't do anything if I were you. And at 36, I mean, you are on a good age group, and your options are restarting the fertility process. You started before you had to stop because of the virus. But the first thing to know is what's the size of this fibroid and where it is located. And if it's located inside the cavity, what you can do is remove this fibroid and then restart the process. If, I have to say as well, because that also goes with the tailoring of the treatment. For example, at 36, you might be worried about what if I remove the fibroid, I go into a waiting list, etc., my egg reserve might be delayed. But there are options like, for example, doing the fertility process, an IVF process, for example, freezing the embryos, leave them frozen, okay? And then dealing with the fibroid. And then once the cavity is fine and you are all right, with regarding your fibroid, then you can do the transfer of the embryos that you already have frozen. So there are different ways to adapt to the circumstances of the patient.
All right. Thank you so much
You're
once
welcome.
again for that answer and your recommendations. Okay, we will go back to the question in regards to chronic endometritis. Okay, so when is it a good idea to check for it, as normally it is not a standard first choice analysis?
Okay, when would I check for chronic endometritis? For example, if you have, it depends on the patient, but for example, if you have a case of patients that have good quality embryos, okay, and you transfer them and they do not implant, that's something called recurrent implantation failure. And the embryos are good, and you think, well, it's not the embryos, it must be something else. So that's, for example, something that points you to check into the cavity. Is there an infection into the cavity? Is there an inflammation into the cavity? That's probably one of the scenarios I will check. Sometimes it's the history of the patient. Like you have a patient who had miscarriages before and had many curettings, DNCs for the miscarriages. I think be careful. I mean, this lining has been, under so much procedures, it might be some residual inflammation. Let's check that before we start the process. If, for example, you have a history of fluid into the tubes, okay, and I think, well, maybe that might affect, if there is an inflammation on the tubes, there might be some retrograde infection, so the infection goes backwards to the lining, and maybe it's worth to do a culture and make sure everything is fine, is in good shape before we do an infertility treatment. So I think that's, some of the scenarios that we check for endometritis is not the first choice anyway, to check for endometritis in a patient that doesn't have a history of previous uterine interventions or doesn't have previous failed cycles. It's not something I will do to start with, but I will do it if the history tells me that maybe might be a uterine factor.
And excellent. Thank you so much once again for that. Next question is right here. So what is normal level of FSH for male?
This one, generally we have an andrologist who is dealing with that. If I have to tell you the exact number, I will be lying to you. I can come back to you later and tell you, okay? If I give you a figure, I will be probably, if I tell you that it's about, that it has to be level than less, the level has to be less than 20, I might be even off the normal level. So if you don't mind, I will tell you later, because we have an andrologist that will specialize on that and will treat males. So when it comes to hormonal levels of patients, that's something we have to report to the andrologist, and he's the one who is an expert on that. It's not my area of expertise. I'm really sorry, Andrea.
Oh, of course, it's not a problem. I can always forward this question to you and your team, and I'm sure you will be able to get back. Yes, no problem. Of course, I made a note on that, so we will definitely get back to you. All right, so let's have a look at the next question. So, is sperm quality decreasing with certain age, more like it is with women? Is there a last call age for men to think of having a child, like it is for women?
Hi. Sperm quality doesn't decrease as much as egg quality with age, but what we've seen is that in men that are approaching 50, there is an increased risk of offspring with autism, and that might be related to genetic ruptures, let's say genetic damage. So it doesn't decrease as much as with the women, but definitely it has some degree of affectation of the sperm with age. So men they keep their fertility much longer than we do, but it's not like is the same the sperm of a 50-year-old than somebody who is 30 years old. There is some degree of alteration, and that has to be taken into account. And especially with men who are over 40, we have to check that they don't have any what's called oxidative stress. It is recommended to do something called fragmentation to make sure that the sperm is not damaged. And because if it is, we might need to do some either lifestyle changes and add maybe some antioxidants or some kind of medication to compensate for that.
All right. Thank you once again. And actually, there is another question in regards to that. So does low testosterone level has impact on sperm quality somehow? Even sperm analysis, everything is okay. Should it be treated first before the IVF?
I think if the sperm analysis is okay, I wouldn't do the treatment of that. As I said before, it's not my area of expertise, and the andrologist will respond to that much better than I do. But if you have a low testosterone and you have to give testosterone treatment, it's kind of you're tricking your body. Your body thinks, oh, well, I have a lot of testosterone. And then the brain starts producing less hormones, and that produces less sperm. So it's kind of funny, but you think the more testosterone, the better. No. If you give external testosterone with medication, it might have an impact on the sperm. So if the sperm quality is good, I think the testosterone level that has implications in other areas, but if it's not having an implication on the sperm quality, is something apart. You don't need to treat it if you're talking about doing fertility treatment. You can do the fertility treatment, and then later you can deal with the low testosterone and how to, which medication you will need for that.
Okay, thank you. And actually, there is a follow-up, so let me just go to that one. What test would you recommend to a 46-year-old male? Just normal sperm test or some special tests to check for possible abnormalities?
Okay, 46 years old male with normal sperm test. I think we need to take into account the whole history. For example, has he had children in the past or not? What kind of occupation he has? Is he dealing with toxics or high temperatures? Is he a heavy smoker? So we need to take the whole history. It's not that straightforward to tell you. But if being 46, if he has, for example, a long history of infertility and the sperm test is normal, thank you. I can see no children, healthy lifestyle. Thank you very much. Then I'm working with PC. Great. Then as I said, depends also on the age of the woman. But if, let's say, his partner is young and we assuming there is good, normal, healthy eggs, and they have a long history of infertility, because you have to take into account the history of for how many years it's been. The test you might do apart from the sperm test could be, as I said before, a FISH, which means that you're checking what is the number of the percentage of a normal sperm in this sample. Okay, so in a sample of sperm, you have millions of spermatozoids. Most of them will be normal genetically speaking, and some of them might be abnormal. Some men have an increased rate of abnormal sperm on this sample. That means that there are more chances that one of the abnormal ones is going to fertilize the egg. Okay, so we check that by doing something called FISH. Or sometimes men might have some kind of oxidative stress on the sperm, and which can be solved by taking some antioxidants or lifestyle changes, I said before. So these are two extra tests you can do if you have a long history of infertility with a normal sperm. There are other things also sometimes worth to study. For example, doing a blood test to check that your chromosomes are fine, that there is nothing abnormal, because you might have some alteration on your chromosomes that doesn't give you any illness. You won't know unless you do the blood test, but it's giving you abnormal embryos. So you will, then you will see that there is no implantation of embryos or either miscarriages because they are abnormal. So if the sperm test is fine and the rest of things are normal, checking a karyotype, so checking the chromosomes of the male on blood, checking the genetic information of the sperm, that's called FISH, and checking fragmentation. These are options that we can discuss.
All right, perfect. Once again, thank you so much for providing all those options and details. And of course, the patients already would like to thank you for that.
Welcome.
Okay, now let's go to the next question that we have. Okay, it's right here. So if partner has astenoteratospermia, can we go ahead with IVF, or does he have to be treated first? What treatments are available for this condition?
Okay. So if the partner has astenoteratospermia, which means that the sperm, the number of so the shape of the sperm is abnormal. I mean, the percentage of abnormal sperm is higher than normal and is going lower than normal, is slow than normal. It depends on the degree. I mean, if it's not very severe, yes, you can do IVF treatment. Why? Because when we do an IVF treatment, what we are doing is we are collecting the eggs of the patient, and let's say we get, just imagine, an average of 8 eggs. That means that I only need 8 spermatozoids, because what we do in Institut Marquès to ensure we have a good fertilization rate, we do ICSI, so we inject the sperm into each egg. So I need a reduced number of eggs. Then, you're mentioning it has the first part, asteno. It means that they go kind of slower, okay? We can check with the microscope which ones are moving faster, which ones are more active. And you mentioned that they have terato. It means that they have an abnormal shape. So you need to choose a sperm that is moving fast and has good shape. And because your partner has that, there is not many of them. So what you probably will benefit from doing is something called IMSI. That means that is a microscope that it increases the vision by 16,000 times. So it's a very, very powerful microscope that helps to select the best spermatozoids. Depending on the degree of this asteroteratospermia, of course, we might need to do some investigations before. Why is it moving slow? Maybe we need to check if it's very fragmented. Maybe we need to do the fragmentation test, because this patient might benefit from 3 months of a course of antioxidants, or might benefit from lifestyle changes. I don't know, okay? So I will say, depending on the degree of the astenoteratospermia, we have to do first some investigations, but definitely there is room for treatment. It's just a matter of choosing the best spermatozoids with, for example, IMSI, or with fertile, that also selects the sperm that has a better shape and movement, and is the best one.
All right, excellent. Thank you so much once again for providing all those recommendations. And well, there are a few questions left, so I guess we will be slowly finishing. However, I just want to encourage everyone, if you have any questions left, this is your time to ask, so go ahead and do it. And the question is right here. So I was diagnosed with some small fibroid. I was proposed to do a mock cycle. The problem is that I should be taking progesterone and estrogen on the 2nd to 3rd day of cycle. The question is, what if I don't have a cycle?
Okay, so I imagine, because you are worried about not having a cycle, I imagine that your situation is that you might not have cycles, and that's why they propose to do a mock cycle. Okay, so because if you have regular cycles, there is no need to do the mock cycle. So what they want to see is that, okay, you don't have your cycle, but what if I give you hormones? Will your lining be able to respond to the medication? Will your body respond to the hormonal treatment? So that's the whole idea of the mock. You don't have a cycle. Well, we give you the hormones to see if you respond to that before you start the proper cycle. You know that you need to know if you are going to respond, what are your chances. So if you don't have a cycle, the mock cycle, well, they can start with no cycle. You can start the treatment the way your doctor will tell you, and it will create kind of an artificial cycle. I think that's the idea, what they have proposed. If it's because you have small fibers, maybe they couldn't see the lining if it was thickening enough, and that's what they're trying to do, see if the lining is thickening enough to have fibers. I don't know the details of your history, really, but small fibers is not a reason to do a mock cycle unless you are concerned about how the lining is going to respond, correct? So I think that's probably where they were heading. We see fibroids. I'm not sure if the lining is going to grow. Let's try. Let's give her hormones, and if it responds, then you are reassured that you will respond when the treatment starts.
All right, thank you so much again for that. Okay, I'm just waiting to see if a patient would like to add something. Okay. All right, let's go to the next question. We will go back, okay, because I think that Andrea is writing still, but let's go to the next question, and we will simply go back to this one. And the next question is actually here. Can a woman without periods do IVF with her own eggs?
Wow. I imagine if you don't have a period, I mean, not having periods, that's called amenorrhea. So it depends what you're having your amenorrhea. Okay. If you don't have a period because, for example, let's say you have a low body weight and you had a dramatic weight loss and then you went into amenorrhea, this patient doesn't have periods but still has eggs. So that means that by in giving hormonal treatment, we can retrieve these eggs. But if you don't have periods because you are running out of eggs, because you went into menopause, then you cannot do an IVF treatment with your own eggs, because what we do is give you hormones to retrieve your eggs. We cannot retrieve what you don't have. So the answer is it depends on why you're not having periods. If you are a young woman with eggs but no periods because of, for example, as I said, dramatic weight loss, or because there is a problem on the lining of the womb and they have some additions where these additions can be treated, so you're not having periods but you have eggs, this woman can do an IVF correcting certain things. A woman that doesn't have periods because she ran out of eggs, then in this case, unfortunately, no, she won't be able to do IVF with her own eggs.
All right, excellent. Thank you for clarification to this one as well. Next question is up. So you mentioned that you prefer IVF with fresh eggs. How is it practically, logistically, and financially possible, taking into account probable failed cycles?
Okay, so practically, logistically, and financially. We have, as I said, we have a bank of donors, okay? What does it mean? It means that we have patients that have been screened and they are kind of waiting for us to call them, okay? So I have my list of donors. I choose the one I think is suitable for the patient, and I call her and she's available. She will start the cycle. Practically and logistically, how we do that? Well, I tell the patients to start, for example, on the pill, and I tell the donor to start on the pill, and then at some point I tell them, both of them, to stop the pill so they get the period at the same time. This is the way of doing an egg donation cycle with fresh eggs. This is the way to synchronize. So I'm synchronizing your periods by giving you hormonal treatment, okay? I'm not sure I understand the financial issue about probably failed cycles. I mean, our egg donation program is very successful. I mean, we have a success of 91% with egg donation. So patients know that if they per cycle means they, as average, they may have 2 to 3 embryos, in total. So after these 3 cycles, your chances are more than 91% of getting pregnant. So financially, I think is a treatment that is worth to do it because it gives you great success. Okay, so I don't know if that answers the question. I'm not sure I did understand the question, but practically and logistically, we synchronize with medication, and financially it's possible because we have a great success rate and it pays off.
All right, thank you. And actually, there is a follow-up, okay? So if you fail the first cycle, you do the second one again with fresh ones?
If we fail with the first cycle, I think we should do with fresh one again, because if you do it with frozen, sorry, you mean fresh ones? You mean fresh eggs or fresh embryos? I might be not understanding well. I answer both things just in case. If you fail the first cycle, but you have frozen embryos, because you might have spare embryos, then definitely you will have to use the spare embryos, yeah, okay, right, you answer now, embryos, yeah. So if we do the fresh transfer and it's not successful, then, and you have frozen embryos, I definitely will use the frozen embryos. That's the aim of the treatment, of stimulating the donors and having spare embryos, that will optimize your chances of getting pregnant because you have more than one embryo to transfer. You have to think that the embryo, we recommend to be frozen on day 5. So these are very good quality embryos. We are very strict with the embryos we freeze. We cannot freeze any kind of embryo because then it will be disappointing later when we thaw them and they don't survive. So we only freeze very good embryos on day 5 with high chances of surviving the thawing process. If they survive, they have the same success rate as the fresh ones in our laboratory. So I definitely will use the frozen. That's the ideal situation to do a cycle when you end up with more than one embryo, and you can use on that same cycle the frozen ones.
Excellent. Thank you so much for that clarification, of
You're welcome.
course. And there is a question here in regards to, you have mentioned 91% when it comes to success rate. So the patient is asking, so are you talking about take home baby success rate?
After three transfers, yes, you are able to transfer 3 embryos on day 5.
Okay. Thank you.
Sorry, we are talking about egg donation.
Of course, egg
Yeah.
donation, indeed. Okay. All right, thank you. And now let me show you the next question. So what is the normal level of TSH recommended for egg donation? Mine is 3.24. Is it too high?
Okay, so a level of 3.24, if you were not trying to get pregnant, regardless if it's egg donation or your own eggs, that will be normal. Okay, so for a woman walking on the street that is not trying to get pregnant, below 4 is absolutely normal. But once you get pregnant, your body is going to change and the thyroid hormones are going to modify. And so we need to make sure you start on a lower level than that. So ideally, TSH should be less than 2.5. Okay, so 2.24 is normal. I mean, you don't have any thyroid issue. But if you're talking about planning to get pregnant, you need to drop it to 2.5. So once you are pregnant, you won't be in a situation where your thyroid is not working as it should be.
Okay, excellent. Thank you once again for answering this question. Next question again is right here. So my husband and I have been trying for 1 year. We have gone through several tests and his sperm analysis came back as teratospermia, sorry. I was just wondering what our chances are to conceive naturally.
Okay, so couple of things. First, it depends on the degree of teratospermia. Okay, so we consider that to be normal to have at least 4% of normal shape in the sperm. Okay, below 4% is called teratospermia. Having said that, that doesn't mean that if you have a 3%, it's impossible for you to have children, and if you have a 10% normal sperm, you will have children. Okay, so that gives you an idea of the quality of the sperm, but is not black or white. Then, if you have a male factor, like is this case, teratospermia, it depends your chance of getting pregnant also on the other factors like age, egg quality. If for example, you're below 35, and then I'm assuming your eggs will be good quality and your tubes are open, you don't have any risk factor for tubal occlusion, then your chances, of course, they are decreased, but they are not down to 0. If apart from teratospermia, it happens that you are, let's say 40 years old and you've been trying, it's not your case, you've been trying only for a year, but you've been trying for many years, then I will say your chances are low and you need to restore to fertility treatment. So trying for a year, depending on your age, you will need to consider to do a fertility treatment already. Up to a year could be normal. From the first year to the second year, there is still a certain percentage of couples who might get a pregnancy, but in your case, there is already a diagnosed male factor. So I think you will need to go into an IVF treatment, and with an IVF treatment, you will have a good chance. Naturally, I cannot tell you for sure. I mean, as I said, it depends also on the female factor.
Of course, thank you once again for clarification to this question and, of course, your question. Next question is definitely interesting. Institut Marquès is known for studies about using music in the embryology lab. Is that right? Do all these centers have music in the time-lapse incubators?
No, I think we are very innovative about that. I don't think all the centers use music on the time-lapse incubators. It's true. There are studies that shows that music might affect, in a good way, the quality of the embryo. So we are big on that. We like that. So we have these little iPods that we can put together close to the embryos, and they definitely have music. Is the music affecting the embryos? In the theory is that this vibration is the vibration of this music that might kind of move the liquid around the embryos, and if there is any particles that might affect the quality or any fragmented cells, etc., they kind of get clean. For, I don't know, it's a way to explain. So this vibration of the music seems to help. Why not? So I think it's beautiful to do that. It's a beautiful idea, and we definitely do that. And I don't think other centers are doing it.
Excellent, thank you. And just a follow-up question. So, and how about Institut Marquès centers? I mean, not only in Barcelona, but in Dublin also, it's an option.
To do the music, yes. Yeah, yes, absolutely. Yeah, in
Okay.
Instituto Marquès, Ireland, Barcelona, Italy, we are the same. We follow the same procedures, except certain things that by law we have to do a bit different, like when it comes to donation. But yeah, we have to use the same resources. We have to use the top resources we have. So, and it's the same everywhere in all Instituto Marquès.
Okay, excellent. Thank you for clarification. And we will go back to the previous question, okay, as there is a follow-up. You mentioned earlier if asterinoteratozoospermia, is not severe, we can go ahead with IVF. So what do you consider severe?
Okay, so I mean, if you, for example, if there is just on the verge, like 4% of abnormal sperm, and there is not a egg quality issue, well, maybe it means that 4%, maybe we're doing some lifestyle changes, maybe you repeat the sample, because you have to think also that sperm quality changes from sample to sample. So ideally, he should have more than one sample to have a proper diagnosis. So if there is kind of like around 4%, well, chances of conceiving naturally, I cannot give you a figure because I don't know. As I said, it depends also on the egg factor, but it's possible to have still a spontaneous pregnancy, even it might be a more difficult. But if, for example, there is a severe teratospermia, like having, because like some men have 0% of normal sperm, that's more severe one that will require selecting the sperm with a more powerful microscope, and it might affect the chances of conceiving because it might affect the quality of the embryo. So first of all, I think just one sample might not be enough. We need to repeat the test. And if we're talking about 4%, that's okay, is acceptable. If we're talking about 1%, that is a severe one. And
Okay.
2% is a severe one.
All right. Thank you again for answering that question. There are a few more coming up here. So can the eggs be retrieved even with a 3.4 centimeters fibroid in the cavity?
Yes. When the egg retrieval, what we do is we do a vaginal ultrasound, and under sedation, with this needle, we reach the ovaries. So we are not going through the uterus. We are not going through the womb. So because we are not going through the uterus, even if there is a fibroid in the cavity, that doesn't affect, is not on the way to the ovary. So yes, we can retrieve the eggs and we can produce the embryos. Another issue is, can we put back these embryos into the cavity? Probably not. Probably we need to freeze these embryos, clean this cavity, fix this cavity, and then put the embryos. But the egg collection, it can be done with fibroids inside the uterus. Only with big fibroids, and I'm talking much bigger than this size she's mentioning, it might be technically difficult if they are on the way to the ovaries. But at 3.4 inside the cavity, that's not going to affect. Technically, is not going to make any difference.
Understood. Thank you once again for explaining that question. All right, next question is right here. Can you let me know what are the options available to me with an elevated FSH of 12.9? We have been trying to conceive for 3.5 years and never had a pregnancy. What are the things we should look out for in starting our first IVF cycle?
Okay, elevated FSH, what it's telling you is that the ovaries are they require kind of more hormonal pushing, let's say, to work. Is a sign of the ovaries not working well.
There is additional information here, okay? So both 30 years old, we are also wondering about the different success rates with going with the basic IVF versus all the optional add-ons such as fertile embryoscope. It's difficult for us to tell if it's worth it financially.
Okay. So the good news here is your age. You're 30 years old. So that's the best thing you can tell to a doctor. 30 years old, less than 35, the eggs are probably going to be, in theory, they should be good quality. You mentioned that you have a high FSH. I don't know if that's been repeated more than once, or it was just one reading. You need to be very careful which day of the cycle you're doing that, because it might be elevated because you're not doing on the proper day. But let's say you have a high FSH, that means that the ovaries are showing some kind of resistance to the hormones. That's why the hormones are elevated. They are trying to compensate this resistance. Okay, then we need to know more things. We need to know, being 30, how many eggs you have. I mean, we know that maybe there is some resistance to the hormones, but how many you have? So how many you have? So you need to do other tests to check your ovarian reserve. I don't know if you have done something called anti-Mullerian hormone. I think that will be interesting to check. And you will require also an ultrasound to see how many follicles you have. It's called antral follicle count. So we need to know, apart from this suspected resistance of the ovaries, these ovaries, do they have a good number of eggs? Can we work with that? The 3.5 years is telling you something, is becoming a long time for somebody who is 30. So you need to, normal AMH. Okay, that's good. So you're 30 years old with with an acceptable AMH. We need to know what is also the sperm quality. So if provided we have an acceptable sperm quality, you have what it looks like an acceptable ovarian reserve, and you are 30 years old, your chances with an IVF cycle are very high. I mean, that's the first thing we look when somebody comes to the clinic, is the age of the woman, because that's going to determine the success rate. That's an important factor. So I think you are kind of in a good position. Good ovarian reserve, 30 years old. Of course, you need to do other tests. You need to check the male factor. But I will definitely go for an IVF cycle, especially 3.5 years. That's becoming, is a long time. I wouldn't go, for example, to other treatments like insemination. It's not worth it after 3 years. The success rate is not worth the time and the cost of the treatment. But an IVF, I think, is definitely for you. I think you are an ideal patient, as a matter of fact.
All right, excellent. Once again, thank you so much for
Welcome.
clarification. Okay, there is a question that is very common recently. When is your clinic opening again for international patients, and how long does it take to arrange a cycle?
Well, the good news, we are open already. Okay, so we have been preparing ourselves for, when the situation will improve, and we had already opened. We are treating already national patients, and for international patients, what we are doing is we are providing some forms, some justifications so they can travel. And we had already a couple of patients who came, and with this kind of form we gave them with this report, they have a report to come here and they have a report to come back home, and with that they haven't experienced any problems. Of course, you might need to explain at the airport why you're traveling here, and they might ask you justification of accommodation if you stay for a couple of days in Barcelona. But we are open for international patients. And how long does it take to arrange a cycle? I mean, once you have all the required tests, it doesn't take long. I mean, we don't have a waiting list to start treatments. So as soon as the patient wants, we can start. We're
All
already
right.
doing cycles, so.
Of course. Excellent. That's really good to hear indeed. Okay. Next question is up. So does high FSH of 76 with no periods affect having egg donation or its successful outcome?
I say no, it does not affect. If you have a high FSH with no periods, of course, that means you have gone through menopause. But egg donation, one of the indications precisely is for women who have gone through menopause. So you have to think that if your egg donor, let's say, is 26 years old, your chances of getting pregnant are if you were 26 years old. So the fact that you don't have periods and you require egg donation is not affecting the egg donation. What we need to know is, because what we have to do is prepare the lining of your womb. Okay, so if you haven't had periods for many years, maybe it will be worth to check with hormones if you will be able to respond to the treatment. So it's kind of a trial, a mock cycle where you kind of dummy cycle, sorry, where we give you hormones, we see if your uterus is able to respond, the lining is thickening, so you will be able to receive the embryo. If it hasn't been a long time since you had your periods, it won't be any major issues. So the answer is you can have egg donation, no problems, even if your FSH is high, doesn't affect the success of the treatment. We only need to make sure that your lining will respond to the treatment you will require to thicken the lining.
Understood, of course. Thank you once more for your advice on this. Okay, there are like 5 questions left and we will be finishing. And well, let me go to the next question. I am 39 and after doing 2 cycles, I only had 2 eggs of 10 follicles. How can that happen? Where can be the problem? My AMH was tested at 1.03. What do you recommend?
Okay, 2 eggs out of 10 follicles. Well, it will be interesting to have a look to the stimulation, to the protocol they gave you. Okay, so it's true that you can have many follicles and not all of them will release a mature egg. Okay, so 10 follicles with only 2 eggs, to me it sounds like a low number, but maybe the follicles were not big enough. Maybe you had small follicles and in reality it was 2 eggs out of maybe 2 or 3 good follicles. I don't know if I'm explaining myself. Okay, so but anyway, regardless of that, 2 eggs is a very low response. So what can you do? An AMH of 1 is kind of low. I will expect you to respond a bit better than 2 eggs, I have to say. That's why we need to review the protocol. But what will be your options? I don't want to talk about egg donation. Being 39, I think we can explore other things. One option will be to try to increase the medication or change the medication and do accumulation of eggs or embryos. Okay, so if you're 39, you might do 1 cycle, and if you get 2 or 3 eggs, and you get 2 or 3 or 2 embryos, for example, Ideally, you should analyze them because you're 39. So having this low response, maybe you want to consider to do more than one cycle to do accumulation. That will be one option. Okay, so review the protocol, change the dose, change the medication, change the way everything was done, and maybe consider to accumulate. Other option, if everything was fine and the dose of the medication was already quite high, and you don't want to go to do accumulation, maybe you want to consider to do an egg donation. I mean, that's we'll have to talk. I need to know your history in more detail. But yeah, there is these two options. There is the option of repeating with different dose and maybe consider accumulating or going for a donation.
Okay. Thank you once again for your recommendation, your advice. Okay. There is another question ready. Do you by any chance know the religious background, or can one request a Christian donor? Do you have donor from the Caribbean as well?
Okay. We do have donors from the Caribbean. I know that. And about the religious background, I mean, not specifically. I asked for that, but when the patients come here, they have a kind of a file registration form, and some of them might write that. What I do because is, if for example a patient tells me I need a donor to be this, or I would like a donor who has interested in sports or in arts, what I do for me is as easy as calling the donor and finding out. So if I don't see that as a difficult thing to do, if it's important. Another thing is the donor might not want to tell me, and if the donor doesn't tell me, then I have to tell the patient, listen, I don't know, or I might look for another donor, etc. But I think it's doable. At the Caribbean, definitely, we have donors from the Caribbean.
Okay, understood. Of course, thank you so much. There is a question in regards to when do you expect to start again with treatments in Ireland?
We have already started.
Excellent. That's good to hear that. Thank you so much. And well, there is one question here. I am 37. I have an AMH of 0.5. After the removal of my right ovary, as I had a borderline tumor, I had a failed IVF cycle in last November with the antecedent of borderline tumor. Is it safe to go through other IVF cycles?
Okay, so if they have removed the ovary and provided the other one is normal, yes, you could go through another cycle of IVF in terms of safety. Another issue is how many cycles you want to do. Your anti-Mullerian is a bit low, okay, but it's true that you're 37 and you still might get some eggs. So in terms of safety, provided you have an ultrasound that checks the other ovary, and yeah, it should be all right.
All right, excellent. Thank you once again for that. And now it looks like it is our last question for today. So let me show you that. Thank you, doctor. That's very helpful. I'm still wondering about the add-ons to IVF. It's regarding the previous question from Ellen.
Oh yeah, add-on, yes, add-on. Well, if I have to recommend about an add-on, for example, the one that I definitely would recommend is if you to transfer the embryos on day 5, not transfer them on day 3. So when you do an IVF and you retrieve the eggs and you fertilize them, the embryos, we watch them, and we can watch them during 3 days, and not on day 3 transfer them, or transfer them on day 5. Ideally, we recommend to go to day 5, because on day 3 you might have embryos that look similar, but if you give them 2 days more, you will have more information of of the quality of these embryos, if they are growing, which one is growing well and which one is not growing well. So it's not that by keeping them 2 days more we are making them better. What we are doing is we are choosing better. So, for example, you have an embryo that on day 3 looks good, and on day 5 is abnormal, it kind of stopped growing. At least you didn't transfer that embryo on day 3, because it would have given you a pregnancy. Okay, so what you're doing is you are putting these embryos through a very tough selection, but at least this way you select only the strong ones. I think this one is definitely worth it, absolutely. And the other, I'm talking in general, okay. The other is, I think, is, I mean, I will go for that with my, definitely is the embryoscope. So I mentioned the embryoscope before, and what they are doing is the embryos are on an incubator. And if you don't have the embryoscope, what's happening is the biologist is opening the lid, is checking the embryos, giving them a score. 24 hours later, he's going to do again the same. Okay, but if you are having the embryoscope, you don't have to do that. That means that not opening the lid means that the temperature and the oxidative stress of the embryos is not affected. The embryos grow better, so that's the first advantage. These embryos are growing better. They reach a better quality, and at the end of the day, that's what you want: a good quality embryo that will give you better chances. Second advantage is that because it's creating a video, you might have two embryos on day 5 that they look pretty much the same. Which one we choose? You want to transfer the best one in fresh, if possible. So if you watch at the development of the embryos on the video, you might decide that one has been growing more steady and better than the other. So you are selecting better. So that's the two advantages. They grow better and you select better. Apart from that, there is the option of having the embryo mobile, which means that these images we are seeing, the patients, they can see them from the mobile. That's another thing that is nice. It gives reassurance, it decreases anxiety on patients. But in terms of success rate, the first two things are very important. Okay. Then other add-on, it depends on each particular case. For example, we do ICSI because we think we know it increases the fertilization rate. Why are we not using the IMSI, the super powerful microscope? Because not everybody needs that. We don't want to do things that patients don't need. Is not fair for them either. So if a patient has a very bad sperm with very bad morphology, okay, he might require an IMSI, but we won't indicate that. So we have to individualize. So in general, I will say the day 5 blastocyst, the blastocyst I would recommend, and the embryoscope. The other add-on, it depends on each particular case.
Excellent. Thank you so much. And I mentioned it is our last question. However, we have a very short one, so I guess we can quickly answer this one. So do you have any African egg donors?
We do have African egg donors.
Excellent. Good to know that. Good to hear this. And well, this was definitely our last question for today. But of course, I want to mention that if you would like to ask any other questions and be in touch with Dr. Trigas and her team, of course, you can use the link I have just sent to you in the chat section. And I'm sure they will be happy to get back to you and provide you even more details. And well, Dr. Trigas, thank you so much for joining us tonight. You've been excellent with answering all those questions. So thank you for your time as well. Well, there are some comments from the patient. There are some thank yous. So I want you to definitely see them.
Thank you for inviting me. Thank you for letting me explain that. I hope everything was, well explained. I did my best. And any comments, please, just you can send us a message, and we do our best to help and resolve any issues, any questions.
Excellent. Thank you so much. And I just want you to see the more. Thank you for this excellent webinar. There are more thank yous coming your way. Thank you so much. Hope to visit your clinic soon. That's good to hear as well. Well, thank you all for joining us tonight as well. I am really happy to hear that it has been useful for you. Well, no doubt, Dr. Trigas, definitely you've done an excellent job indeed. It was a pleasure to host this event with you, and hopefully we'll be simply able to do it once again. I would love to have another webinar for indeed. And just let me remind everyone that this has been recorded. So of course you will be able to see it on our website, myivfanswers.com, and also on our YouTube channel. So I encourage everyone to simply subscribe to our YouTube channel, and that way when the video is uploaded you will be notified. So and of course there are more events coming up. So tonight again we will start within the next 30 minutes with another topic with another doctor, so I hope you can join us as well. Dr. Trigas, once again, huge thank you.
Thank
Have
you.
a lovely evening
The
and
same
take
to
care
you.
everyone. Thank you.
Thank you. Bye.
Bye.